can get you started. So again, we have a great turnout. Good morning. Thank you everyone for joining us. We're actually right on time as we start around 7:05. So thank you guys again. And so obviously our speaker this morning does not need an introduction. And many of us have worked with her and known her for many years. So Dr. Erika Woodson is our section head in urology and lateral skull-base surgery. And she's the medical director of the hearing implant program here, and also a previous chair of women in otolaryngology, so lots of accomplishments. And so she initially completed her medical school at Virginia Commonwealth University, and then completed her residency and advanced fellowship at the University of Iowa. And her current interests are in functional and hearing preservation in cochlear implantation, as well as lateral skull-base surgery. And she's a pioneer in endoscopic lateral skull-base surgery. Many of us have heard and obviously know that she has been recruited to take a prestigious leadership position in lateral skull-base surgery in Kaiser Permanente in South California. As you know, she's been a tremendous teacher, mentor, and an advocate, especially for women in otolaryngology and here as Head and Neck Institute, and just a dear friend. So we're going to miss her dearly. And, this morning she'll be giving us a talk on frontiers in cochlear implant candidacy. So thank you, Erika.
Okay, thank you. Thank you for that introduction. And it's like a little bittersweet that I finally, I get this opportunity to present everybody about something I'm really passionate about, just kind of like on my way out the door. Like, I'm just going to drop some knowledge and I'm going to run the other way. But I'm really excited to be able to do this because this is something that I feel very, very passionate about. And that is that we do not do nearly the job in recognizing people who would benefit from a cochlear implant kind of in the community. What does that number actually look like? Well, in fact, it's about 10% or less. What is this? Is there a way to make it forward? Okay.
I think we're muted.
Can you hear me?
Yep.
All right, I'm hearing somebody's music.
I think it's Suwat. Suwat,
No.
you know.
We're logged in.
I think Dr. Woodson is presenting under Suat, right? In the room. Is that right? Because we can't hear you anymore. Can you unmute yourself?
All right.
There we go. Thank you.
Okay. Okay. So we are going to do some off-label discussions because implant indications have not advanced quite like we have in the implant centers as far as the FDA indications. And so we're going to talk a little bit about some of the objectives this morning. We're going to recognize some of the real-world challenges for patients with sensory hearing loss. Because I think that's one of the keys is that we're so used to just sort of looking at an audiogram and inferring how a patient does in the real world. But the audiogram is not the real world. An audiogram is like so far away from the real world. You really have to start thinking about how different degrees of hearing loss affect somebody so you can figure out where amplification as well as cochlear implant comes in. We're going to discuss a little bit about single-sided deafness this morning. That's one of the newer FDA indications for cochlear implant and one that has opened the doors for all sorts of great patients to get tremendous benefit. And that's something, though, that's still a little under-recognized. And then we're going to examine some of the changes that we've gone through cochlear implant evaluation so you understand how we started to push that line and pick up those candidates that were poorly recognized before. This is important because you guys are just used to kind of being on the back end of it, but you really need to know how we get there as far as the candidacy and the assessment of that, trying to make the test a little bit more real world than it currently is. And then we're going to talk about the actual changes in FDA labeling, as well as obviously just evaluating and identifying patients who could benefit. So what happens when you have hearing loss? All right, probably one of the first things that happens is you start to lose a little bit of ability to understand and background noise. And this can show up before clinical hearing loss actually shows up, all right? This has happened to me already. Does this happen to anybody? You guys really got a restaurant, you're like, sorry, can't hear you. What? Can't hear you. So this can happen even before we start getting clinical hearing loss. We can start to lose our signal to noise ratio, all right? Meaning our ability to pick out what we want to hear over the background, over the noise, okay? And so we all experienced this over the past couple of years with things like masking, with all these like screens and everything. All of a sudden, all of us started to have more difficulty understanding certain things in certain situations than we would have before. So then what happens is you start to get more hearing loss as you start to guess at words, all right? And what happens when you're doing that is you're not just taking auditory information in, but you're also inserting your brain into it. You're having to think harder to be able to fill in those blanks, okay? And as that occurs, that results in an increased cognitive load of listening. Like you gotta think, not just listen, you gotta think about what you're listening to. So we can see this in individuals, for example, like if you're listening to, say, somebody in a second language that you're learning, right? About how much harder you have to think about every single word that comes through. It slows everything down, okay? And then as the hearing loss decreases and the cognitive load kind of becomes too much, you start getting socially withdrawn. People just start saying, oh, you know, Grandma, stop going to church, or, you know, I don't like to go out to social things anymore because I feel like I just sit there and smile and nod and I can't keep up. And so that becomes very socially isolating for individuals. And then what happens if you get socially isolated, you don't hang out with people, is you get accelerated memory loss, and that can actually result in some cognitive decline. All right, so these are really real implications. I love this picture because it really kind of drives home the fact that hearing and listening are related, but they are not the same thing, right? Like I tell people all the time, like, look, man, I can fix hearing, but I can't fix listening. You got to do that, okay? So you can see how busy the brain is when it is trying to process speech. Again, this is more than just sound awareness. This is about understanding what somebody's saying. It's using a whole lot of the brain. It has to use memory, language, executive function. There's a whole lot going on right there. And we talked a little bit ago about the cognitive burden of listening, and harder listening tasks do require more concentration. And I try to explain this to patients as if like, well, you got just too many apps open on your phone, okay? The more apps you have on your phone, the more it slows everything down, all right? So the more concentration you have, the less working memory you have. So if you're actually thinking hard about what you're doing, then that short-term memory has a few more little gaps and hiccups. So there's different things which can result in what's called an acoustic challenge, okay? So there's the listener, meaning how well they can hear. There's the speech. So this is like when you're listening to somebody in a language with which you're not familiar, or someone who has, you know, a heavy accent, or if they're in a mask and they're not articulating well. And then there's the environment as well. So that's things like background noise, if there's competing talkers, all of those sorts of things blend in to how difficult it is to understand in that circumstance. And then I love this right in the middle, cognitive and multiplied by motivation results in listening effort, okay? And so, all right, you can also just like tune out, right? Anybody do that around here? Yeah, so you can just tune out and just not listen, and then it doesn't tax your brain, okay? But you're not also tuned in then at that point. So there are ways that they can measure how well somebody's concentrating or how much effort they're giving it by their physiologic responses. So that's things like if their pupils are dilated and if they're sweating or what their heart rate's doing as they're listening. And if we give somebody acoustically clear speech, it's not that difficult, and we start giving them acoustically degraded speech to try to tax them a little bit, we can see that there's all sorts of different parts of the brain which start lighting up as it tries to contribute to the task. Okay, so again, the bottom line is listening takes your brain, okay? And if we do not address listening, if we do not address the hearing part of listening, then the reduction in cognitive performance is substantial, okay? Look at this statistic. 25 decibels of hearing loss is the equivalent of being 6.8 years older, okay? Now, it doesn't work if you're 14 and all of a sudden you're 20. I wish that would work, but nope, no, that's not how it works. But almost. But what it does mean is that your patients who are getting up in years are going to show up as older, kind of mentally when you're looking at them, okay? And we see this because it actually affects how people perform on a lot of mental status exams, because a lot of those mental status exams rely on the patient responding to an auditory cue, okay? So if they're not hearing well, they're not going to be able to respond well to that task. All right, and social isolation is significant, all right? We are coming through a pandemic, not just COVID, but of social isolation. And we saw, I don't even know how many patients during this time period that had really steady auditory performance, and all of a sudden, these older people just were socially isolated, just completely cut off. Boom. Their hearing didn't really change. Their sound thresholds didn't really change, but their word recognition and their aided ability were limited. It's because they were sitting at home, they weren't listening, they weren't practicing, they got used to wearing the hearing aids. The social isolation, the lack of practice on its own causes a degradation of being able to speech understand, okay? But look at these statistics. And for hearing loss, if you have significant hearing loss, you're much more likely to be seen as socially isolated or rate yourself as socially isolated. Look at that statistic, 3.5 times for women, okay? 1.1 times for men. So this is a really significant kind of social issue as well. So how do we assess listening ability? Well, the basic thing is just look at the audiogram, right? And as I just said at the beginning of the talk, listening ability and understanding tone or listening to tones is very different from being in the real world, okay? You're focused. There's nothing else going on. There's no distractions. You're sitting there like ready to go, all right? That never happens in the real world, and it's this perfect acoustic environment with nothing competing for your attention. So the challenge of using this to screen for someone's hearing ability or aid ability is that it's not the real world, all right? So it's unaided, it's quiet, and then you have the discrepancies that occur if someone is getting a recorded word list versus a live word list. Standard at the clinic, all our audiologists are going to use recorded word lists, okay? They're harder, all right, they're harder. But if somebody is giving the individual live word list, like they're just saying the words, you know, they can change their speech, they can change their inflection, sometimes they don't even cover their mouth. So that can more than double what their word recognition scores are compared to what a standardized recorded word list would be, all right? That's really critical if you guys are assessing an outside audiogram and that word rec was too good for where they are. You got to ask them if somebody was saying the words to them or if they were using a recorded word list, because it should be written on the audiogram, but frequently is not. And many times those discrepancies are due to a recorded word list versus a live word list. Okay, this is important for cochlear implant stuff, also really important when we're assessing somebody with acoustic neuroma. Okay, all right. So the audiogram also importantly does not predict candidacy. And this was a super interesting study that was published a few years ago by one of my colleagues. And basically he said, and I'm sorry, the little window's over here. I'm gonna try to move it to the side for a sec. All right, so this is the patient's earphone aided difference in word understanding versus aided testing. So in other words, like how far apart their word recognition score was from their aided speech score. So you can see for a lot of people, it kind of lined up there in the middle, but look, a lot of people were 20, 30 points off. Some people were almost 40 points off. And rarely, you know, were people more than that, but you can see there's a huge spread here of how much worse people were in the aided condition and more real world condition than they were on the test. So if you're looking at somebody who might be close to the line on an audiogram, actually they're probably over the line in the real world, all right? So how do we gauge cochlear implant candidacy? How many of you guys actually know what goes into a CI evaluation? Well, the first thing we do is assess the hearing aids they're wearing, all right? We take the audiogram, and they have this cool machine they plug it into with some of the measurements off the ear canal, and then they basically spit out how well the hearing aid is likely doing for their audiogram. So then at a glance, the audiologist can tell if the hearing aid is turned up too high, not turned up enough, or is right in the middle. And we want somebody who's not at the high or the low part of it. We want somebody who's kind of running right along, so it's got some adjustment room up and down. But we basically want to make sure that their hearing aids are adequate for them. But if they're not, they will plug a pair of hearing aids, the clinic pair of hearing aids on to measure their performance between their aids and the clinic aids. And sometimes there's just a profound difference even just doing that. Sometimes that'll just double what they're doing with recorded. So the first thing is check their technology, all right? Check their technology. And then we do listening tests, okay? Now, when I started in your position, basically we just had hint sentences, all right? That's hearing and noise test, right? These are sentences designed to be given a noise. We were giving them to people in quiet. Super easy test, all right? But so that means that everybody that I was implanting, when I was your age, was deaf as a post, okay? And we weren't catching anybody who was higher than that. Like I have a set of flashcards in my office that I used to use on morning rounds. Hi, I'm Dr. Woodson. Are you having any pain? We're gonna change your dressing now. Smile for me, close your eye. Like I had it all in flashcards because these people couldn't understand anything. And so, you know, as we evolved, we understood that this was too easy to test and we were missing a lot of candidates. So then we kind of bumped that up to the AZ Bio test, which is another sentence test, but includes slightly more different voices, different cadences, things like that. So you're not just checking one simple voice to understand. And what's cool about the AZ Bio is it was titrated to give in quiet, and then you can also introduce different amounts of noise, okay? So we could start kind of dialing in the noise and seeing how patients did. Did they fall apart or did they maintain their understanding, okay? And then we're like, shit, that's still pretty easy, isn't it? Because you can use your brain to fill in these gaps, all right? So really high functioning, smart people were still showing up better on the test and they were reporting that they were doing it in real life. So then we kind of bounced up to using just phonemes or just words. And that takes the context right out of it, all right? And that way you can pretty easily see if somebody is using a lot of cognitive load to kind of get over the hump of the hearing. And if you actually drill down on it, what are they actually capable of understanding with just the listening skills alone? So this is an advantage. This is an example of a patient that we saw a number of years ago. And look at this audiogram right here. And if we look at the audiogram, we can see that the patient had pretty even hearing in both ears. And in the low pitches, it was pretty good. And then in the high pitches, it still looked like it was potentially aidable. So you look at this person, you're like, man, you know, I look like they're doing okay. And you got word understanding 60% in both ears. So you're like, looks like he's doing okay, right? But this is a priest, and he's telling me he can't understand anybody, any of his parishioners. He couldn't do confession anymore. This was a major problem. So clearly he was not doing as well as his hearing test would predict, okay? So we checked him with the AZ Bio test, and with his own hearing aids, he scored 10%, right? Pretty crummy. We checked him with our hearing aids because his hearing aids weren't doing a good job. He thought it was amazing because all of a sudden he was hearing 43%, but 43% is still well in the range of cochlear implantation. The other thing one must do is separate out the two ears. Sometimes one ear is much better than the other, and the two ears together are synergistic. So if we measure both ears at the same time, we may also kind of overestimate what somebody's ears are individually capable of, all right? So we already talked about what his scores look like there. And when we measured each ear individually, so he was 43% together, we split those ears apart, all of a sudden they're doing 10% and 24%. So each of those ears individually was performing very poorly, okay? So let's start that off and talk a little bit about standard traditional cochlear implant criteria, okay? Because this is going to be the basis for which we then talk about expanding criteria and recognizing more people. All right, so the most inclusive, the most eager to get implants people are definitely the implant centers, like us, right? Like we are seeing patients who are having tremendous benefit as we sort of push the line a little bit, okay? And then the most stringent is going to be Medicare, all right? And somewhere in the middle is the FDA, and then patients and commercial insurances are willing to cover. Okay, so what is traditional criteria? Traditional criteria is less than 50% understanding of sentences, not words, sentences, in the ear to be implanted, and less than 60% in the contralateral ear. Okay, so so that means that both ears have to be struggling. And again, that's a sentence test. All right, Medicare criteria. I hope y'all all know this, but if you don't, Medicare criteria is way behind. It is less than 40% while listening to both ears at the same time. That's a condition. All right, that's pretty crummy, right? We've had patients who just turned 65 came to see us because they just got on Medicare and went, you would have qualified a year ago, but not now. This creates a massive donut hole for coverage in patients who are the most vulnerable to the side effects of hearing loss, the more elderly patients. So how do we take a bite out of the donut hole? We use ear-specific testing, again, because both ears listening together tend to perform better. And again, we like to use a little bit of background noise, we like to drop the volume a little bit, we like to do words instead of sentences to try to really demonstrate, particularly to commercial insurances, how somebody's really struggling. Okay, Medicare, there's no asking, right? You just got to follow the rules or they put you in jail, and I don't want to end up in jail, so I follow the rules. Okay, so Medicare criteria, true fat has not changed since 2005. 2005. What was going on in 2005? There was like podcast, this new word. Mariah Carey was singing other than at Christmas time, and Hurricane Katrina happened, and that was the last time they updated the candidacy criteria. So Medicare is like way behind. There are some movements now. They may start adjusting the criteria. There's been a lot of advocacy in that area and some new developments, but again, right now, they kind of preclude sequential implantation, meaning if you're really using the best aided condition, once you implant one ear, then almost everybody is performing above that 40%. So different institutions, kind of interpret that rule differently. We interpret that rule as being, you don't get a second ear if you're performing above the line. But some institutions definitely take a more liberal approach. Again, Dr. Sadlowski and I are just afraid of prison. All right, but after cochlear implantation, right, so we did implant this guy, spoiler alert, we did implant this guy, and he has done tremendously well. I want you to look at each of those individual scores. Like he's at the ceiling. He's at the ceiling of those scores. Obviously, everybody shows their best examples and they're giving a talk. But just to reiterate, this is a guy who was not referred in for a cochlear implant. This gentleman came to us because he was struggling, and then we were really able to keep him in front of his parishioners and doing what he was passionate about for much longer. Okay, so there's been a lot of work recently in trying to screen patients for cochlear implant candidacy. As you can see from the testing and the rigor that goes into verifying the hearing aids, it can be a lengthy process. So we want to try to find the people that we need to review, that we need to test without wasting a lot of people's time and without missing candidates. So the right screening test to determine who should go through the full battery, all right? And there's been a lot of times people try to do this. They've tried to just looking at word understanding. They've tried looking at pure tones. This is one that one of my colleagues did a few years ago and saw that if you looked at patients who had a pure tone average of greater than 75 and a word recognition of less than 40%, it was very likely they were going to meet Medicare criteria. But again, we talked about how that's just scraping the bottom, and that's missing a whole bunch of patients on top of that. So the more recent thing has been the 60-60 rule, which the implant companies love because it's super easy to remember. 60-60 rule, word recognition of 60% or less, and pure tone average of greater than 60. All right, people love it because it's simple, and it does an okay job, 93% sensitive, but only 65% specific. Okay, so it is still missing a number of candidates. When we looked at our own patients here a couple years ago, we saw that if we use 60% or 60, then we were able to capture a lot more patients who were meeting cochlear implant criteria. Okay, quite a bit more, in fact. So you can see that we were catching 46% if we used and we were all of a sudden collecting 86% if we were using or. All right, so that's a pretty significant difference.
And what the false, like, I guess, what's the specificity when you use for?
It's a little less. Yeah, it's a little less. That didn't make it on the poster. All right, but it was not as good, all right, but it wasn't that bad either. We weren't wasting a lot of time. We were finding a lot more candidates than we were assessing patients who were not candidates. And we saw a lot of people who were really close to the line who have subsequently become candidates. And importantly, through our screening process, we've identified a lot of patients for whom their hearing aids were really not up to snuff, okay? And as a business model, that has meant that they've retained a lot of those individuals as hearing aid customers, okay, in route to at some point potentially becoming an implant candidate. Okay, so who should you really send? Pretty easy, gonna keep this simple. If you're seeing a patient in the office and they cannot understand you in your mask, they are likely an implant candidate. If patients tell you they cannot talk on the phone, it's likely they've been an implant candidate for several years, okay? And if, you hear that grandma and grandpa has become socially withdrawn, or so-and-so's thinking about retiring because they just can't keep up with things with the hearing, that's also a pretty significant indicator that their hearing loss is being underserved, okay? So I said at the beginning, only about 10% of potential cochlear implant recipients get a cochlear implant. That's before the single-sided deafness stuff came up. This is talking about people who can't hear in both ears, all right? And when we started a SOLVE project, which by the way, you guys should, if you're at all interested, you should totally do. It is so worthwhile digging into doing coursework for continuous improvement and learning about that process and how to make it work. But we did a SOLVE project in 2017 where we looked at our own internal candidacy rates, and then we had developed some screening tools to try to help our audiologists identify more people. All right, and so what we saw is we were getting about 17% of referrals internally. So we weren't even doing a good job in-house of identifying these people. But after we instituted some of our identification tools, we got about 40%, okay? So who's not coming in? Maybe people who don't want to, okay? And there are still some gaps in recognition between the audiologist and the otolaryngologist that we're still likely trying to close. It's one of the reasons I'm talking to you today, okay? So now we're going to kind of shift to off-label a little bit. We've been talking about people who can't hear in both ears, but there's a lot of individuals who have single-sided hearing loss or really asymmetric hearing loss. Meniere's disease is a really classic example of that, all right? So this is an example of an individual who had bilateral Meniere's disease, okay? And one ear was performing pretty well, but was up and down, and the other ear was just toast, all right? So this is an individual that, depending on when you caught him, maybe he was able to get by and maybe he wasn't. Okay, and this individual we were able to implant off-label because we were able to catch him on the down, but what we were able to do was get him an implant and see how well he performed, all right? So this is an individual who is scoring 13% pre-op, 67% post-op in the single ear, but we add both ears together, and all of a sudden he's performing much better because that other ear wasn't offline, but it was just struggling to do so on its own. And some individuals, we see that if they have a bad ear and a good ear, you try to amplify that ear, you actually degrade the speech. Like sometimes we see that actually binaural listening is not as good as monaural listening if they have a really firm ear. And that was the case in, I think in this individual as well. But we can see that again, if we just give that bad ear boost, all of a sudden the vocal listening is far better. There's a lot of synergy going on. Another thing I can point out on this slide is that we use other qualities of hearing. We don't just use speech understanding scores. We also use things like tinnitus handicap inventory, the SSQ, which is talking about quality of hearing in different environments. And these individual scores improve dramatically. I want you to circle in on this tinnitus handicap score. Look at that. Pre-op, they all have bad tinnitus in Meniere's patients, right? So their score was 60 out of 100, which is a pretty terrible score. And then 1 month post-CI, they were down to 16, all right? What this means is that when they're wearing their implant, we're basically dialing that tinnitus way down, in many cases off for individuals. That's pretty profound. We're going to talk a little bit about residual low frequency hearing. I'm going to dive into this a little bit further when we're given our second talk. after the grand rounds talk. But we do see a lot of individuals with low frequency hearing that's still in aidable range. And I think that's what's precluded a lot of these individuals from being referred over in the past, because like, oh, you still got a lot of hearing, you know, and people kind of see a cochlear implant as a last resort, okay? But there have been hybrid cochlear implant criteria for quite some time now, since 2012. That's when it was FDA approved. But basically it allows patients to have normal or near normal hearing levels in the lows, and then they get this sort of ski slope drop, okay? So those individuals, they've always been kind of deflected from CI Candidacy in the past because they still had this hearing and do you want to risk it? But the problem is they don't have enough hearing where it counts to have word understanding and speech understanding. And you really can't well aid that ski slope or the profound parts in the highs. So what the hybrid strategy is trying to do is trying to put a cochlear implant in the basal part of the cochlea to hit the highs, and then you preserve the high frequency, or excuse me, the low frequency information in the apex of the cochlea, and then use a hybrid strategy, a blended strategy, to have the full complement of hearing, all right? So that means that you have the hearing aids in the lows, and then the implant kind of kicks in where the lows cut off, and then you have the full spectrum of hearing, all right? And that means you can have lower pitch hearing than a cochlear implant can provide, and much higher pitch hearing than a hearing aid can provide. So it really is kind of the best of both worlds. And that allowed us, that FDA criteria is what allowed us to start kicking words in and not just sentence scores for speech understanding. So the hybrid criteria is up to 60% words that you're going to be implanted, all right? Not 60% sentences, 50% sentences, in fact, is traditional criteria. But all of a sudden now, with hybrid, we go up to 60% words, all right? So you can see what sort of a quantum leap for candidacy identification that was. But contralateral can get to 80% words. Okay, so not all the insurances cover the hybrid criteria, but it did open a lot of doors for patients who had been deflected, deferred, or not referred in the past. So again, it's a combination of a hearing aid and a cochlear implant working together in the same ear, all right? That is electroacoustic hearing, okay? That is hybrid hearing, all right? Now, if we have a hearing aid on one side and a cochlear implant on the other, that is not hybrid hearing, that is bimodal hearing, all right? That's using two different listening strategies, but only one in each ear, okay? And so again, we got the acoustic parts of the hearing aid and the electrical parts for the highs, all right? So this is a case report of somebody who went this route. And this individual was studying to be an audiologist, all right? So all of a sudden, you know, it was really critical for her where she was, running up into some walls as far as her listening ability. And she had a strong family history of hearing loss. So, you know, she was compelled to go into that field based on her family history and her experience. And you see how well those lows look. They look great, right? Normal, then boom, nada, right? And she was scoring on the sentences 30, 35, words 24, 12. We did a cochlear implant on her, a hybrid, and we got her up to 92% sentences, 72% words in the ear we implanted. And we preserved those low frequencies at their preoperative level, all right? Do we always do that? No. Are we pretty good at it? Yes. Do we expect to see some shift or change? Many a times. But if we can preserve those lows and give them the highs, then we've done that patient a tremendous service. There's her post-operative audiogram. Okay. So single-sided deafness, we're going to shift gears and talk about that for a moment. This is something that, man, it just opens so many doors for so many people. Coverage with the commercial insurance is still a step behind. We spend a tremendous amount of energy within the program doing appeals for these individuals. But the results have been so darn gratifying. And this is where it really hits home. Before we had the cochlear implants offer patients, the only thing we could do was reroute sound. We could say, all right, well, we can send everything in through the good ear. So we can just take things from the bad side, send it over the good side. So that's cross-aid, bicross-aid, also the Baja, Ponto, those implants. All that stuff is just taking things from the bad ear, send it over to the good ear. All of a sudden, we have the ability to give somebody the bad ear back so that they can get back to a two-ear situation. Dr. Sidlewski, I love this analogy. She likes to, kind of compare it to giving somebody crutches if they're missing a leg versus giving them a prosthetic leg. All right, what's going to result in faster, speedier ambulation. And there's a lot of benefits to binaural hearing. All right, and And not all of these are apparent, you know, at the beginning level of understanding hearing loss, all right? There's sound localization, that's like binaural hearing 101, right? You need 2 ears to use the Doppler effect to figure out where sounds are coming from. So if you only have 1 ear, you're really, really bad at doing that, okay? And if we give you a cross egg, guess what? Still 1 ear, still sucks, not good, okay? But if we have 2 ears listening, we can do a much better job. It is best if the 2 ears are listening with the same strategy. So hearing aids versus cochlear implants, if we are having one strategy 1 ear, one strategy other, it's still not perfect. It can be about 20 degrees off because there's different temporal and spatial cues that are coming into those simulation strategies, but still it's a lot better than not having a clue. That can be important for safety, like somebody's in a parking lot, they're trying to figure out the sound, if a car is coming up behind them, things like that. But just in everyday life, figuring out where to turn when somebody starts talking to you, okay? Then there's the obvious head shadow effect, like if you're driving in a car, your bad ear is towards your passenger, you can't hear them very well. So that is something that one can get back from a cross strategy, but you can also just hear directly over there, which leads to our other benefits. First of all, binaural summation, which is just you hear more when you have both ears at the same time. And if you want to test this for yourself, you can just cover one eye, so you're how well you see, and then bring your eye back. Like, holy cow, I see so much better. Each of my eyes individually sees okay. I have them both together, all of a sudden, there's just a lot more depth and clarity. Okay, and then squelch. That's the coolest word in audiology. Squelch, basically what it means is when you're listening with both ears together, as you can see in that diagram right there, when you're listening with both ears together, your brain is actually able to pick apart what it wants to hear over what it doesn't, okay? And so the squelch advantage adds about 10% to word recognition, just straight off the bat, having 2 ears instead of 1 in noise, okay? Really, really important. So there is a tremendous tax to going through life with 1 ear, all right? Then, and this is something that we've really kind of evolved to understand. I mean, it's been known in the literature that kids that have single-sided deafness, kids that are born with single-sided deafness, are far more likely to have to repeat a grade, be diagnosed with ADHD, things like that. So that's something that happens that we've known about with kids. But people have been kind of poo-pooing, or I guess not really emphasizing how important binaural hearing is to the adult, right? But it actually really is important because of that tax you're paying all day, every day to pick things out of background noise. It results in you have to increase your listening effort. You have to think a little harder before you respond. Again, people by the end of the day will tell you they're just tired. They're more tired, they're more exhausted. Having this knowledge and seeing how this is developed has really changed the way I counsel everybody for single-sided hearing loss, including patients that maybe just didn't get a good result from their cholesteatoma surgery or their ossicular reconstruction. I'm much more likely to push some sort of rehab for those people because they've just been like, well, you know, I've been like this for a long time, so I'm pretty used to it. They don't even remember what 2 ears are like, and you give them that back, say like through a like a Ponto, or even sticking a hearing aid on them, or give them the OCR a second try. And these people are, it's like a life-changing experience, and there's someone you almost have to convince to try because they think they're doing okay. They just get so used to that tax they don't even realize that they're paying it. Okay, the FDA criteria for single-sided deafness was based on the study that was used to get it approved. So it's actually pretty restrictive, all right? It's overly restrictive. So they want that ear to be pretty much deaf as opposed, right? 90 decibels, pure tone average, and a word score of 5% or less in that ear. We were just discussing 50%. We were just discussing word scores of less than 60%. All of a sudden, it's 5%, right? Which means that it's actually really, really restrictive. The rules also say that somebody should have a month-long experience with cross-aid. Well, what's cross-aid going to do? Do anything? Anything? Not going to bring it back. It is not going to give them the benefit. But it has created, it's both opened some doors, but it's made those doors a little bit narrow for a lot of patients to squeeze through. And so there is a lot of room to move and embellish in this area. They also need you to have functional auditory nerve. That's important. So if you lost your auditory nerve with an acoustic neuroma surgery or something like that, you're not going to benefit. And the recommendation is 10 years or less of deafness. All right. I get a little casual about that if somebody's not totally profoundly hearing loss. like for example, if they have, reasonable lows or somewhat able levels, if it's been more than 10 years, but they still have some auditory stimulation, I'm more casual about it. I'll go 12, 15, kind of depending on the levels. But if somebody's profound, the longer you go, the worse outcomes they get. Again, just presumably because of spiral ganglia and neuron survival. Okay, and the FDA criteria also says they want those patients to be 5 years older or more. When we know that the critical window for plasticity and best outcomes of cochlear implant is that you get it in the child within 2 years in the cases of congenital deafness. All right, so the cross, the bicross, the osseous implant, kind of discussed that a little bit already. They're descendants down to the bad ear to the good ear. Bad ear to the good ear. All right, regardless of strategy, bad ear to the good ear. All right, and so we don't get the sound localization, we get less benefit in noise. But the other thing is we don't get any tinnitus suppression. A lot of these individuals have pretty significant tinnitus related to the mechanism they're lost. You lose hearing suddenly or with Meniere's disease or whatever, a lot of those individuals have some pretty significant tinnitus. Importantly, patients who have single-sided deafness also rate their handicap related to the hearing loss at the same level as people who have bilateral hearing loss. So whether or not they show up the same way on scores, how they rate their difficulty is also analogous to patients who have bilateral hearing loss or hearing loss in both ears, or it's asymmetric. But let's talk about tinnitus suppression. This is just the coolest thing ever. Like, maybe patients are like, well, but you tell them you can turn off your tinnitus or you can turn it down, and all of a sudden engagement on the cochlear implant discussion goes through the roof. Okay. So in a systematic review, we saw that about 90% of individuals had improvement in their tinnitus after cochlear implantation. Wow, that's a pretty high number. It's rare for somebody to get it worse. You can see that number is about 5%, and nobody had new tinnitus in this systematic review. So a lot of patients got a substantial improvement. These are some of our earliest outcomes that we reported specifically related to tinnitus suppression when patients had a cochlear implant related to single-sided deafness, okay? So in the beginning, we were doing patients who were really, really profoundly deaf for a very long time, because those are the ones that you get approved, okay? But you can see that all those individuals' tinnitus handicap scores went from pretty significant levels down to really insignificant levels, those first 3 patients that we reported on. That was in 2016. And this is a case report of a woman. I actually showed her CT scan a couple of slides ago. She had a fracture right through her labyrinth. She was pregnant. She fell down the basement stairs. She fractured her cochlea. She'd been deaf in that ear, totally deaf for 8 years by the time she came in to see us. And so the contralateral ear was totally normal. We were able to get her approved and implanted. And I want you to look at these scores. So the hearing handicap, she was rating her handicap very high, despite having normal hearing the other side. And it dropped to really minimal levels and did so very quickly after activation. And that tinnitus handicap also went right on down. And her ear-specific scores went from 0 to 83. Again, a great example, but not an unusual one. All right. And this is an individual who even had radiation-induced hearing loss. This is an individual who had a glomus tumor, and I debulked it, and then I radiated it, and then about 3-4 months after her radiation, the hearing just dropped to profound. I felt terrible. We tried her with steroids, no recovery. All right, and so she had a goose egg on her speech scores. And, she had the Cleveland Clinic insurance, so we were able to really advocate on her behalf, and we were able to get her implanted within 5 months of her loss, right? And then she went, with some time and training, from 0 to 94% quiet, okay? Words, the hard stuff, up to 84%. So she really hit the ceiling on even the most challenging listening tests with that ear listening alone. And this doesn't happen automatically. Patients have to be committed. They have to understand this is a commitment. It's not a hearing aid. And it requires intensive auditory training using just that ear practice alone, kind of like covering up an eye if you're trying to train a lazy eye. Do more. Same thing. You have to distract the good ear so the bad ear can flourish. All right. So there are still contraindications to cochlear implant, but they're still a little fuzzy. All right. Get a little fuzzy with that. a lack of a functional cochlear nerve, well, you have to have a nerve to take things back, right? But you get, you know, it's like, well, we think that nerve might be functional, all right? Retrocochlear pathology, here's two good examples of that. We have an acoustic neuroma, and then we have neurosarcoid. That's that leptomeningeal enhancement in this particular individual. And so, you know, those people don't do as well if they have retrocochlear pathology, but we'll still try it. A lot of times if we can get it approved. With schwannoma, there's actually been a number of people who have tried to take the schwannomas out and then implant the cochlea at the same setting. And the results with that have been all over the chart. All over the chart. So it's really hard to get them approved. It's really hard to say that it's something to offer most patients or many patients. Some patients get open set understanding. Some people, you know, get sound perception. And the one that I did didn't even get that over time. And then obviously if one has chronic otitis media, like perforation or chronic mastoiditis, or they have a bowl or something like that, you have to address that in some way so they have a healthy, dry ear space to put a cochlear implant in. Okay. So in summary, we've discussed a whole lot of things all at once. But in summary, the big takeaways that I want y'all to have are that listening is more than hearing. And you really have to understand where your patient's coming from, where they're talking to you about their hearing loss. All right, and you have to look beyond the audiogram and know that people fall apart earlier than that hearing test would predict. All right, again, listening is a combination of hearing and processing. All right, and then there are gaps that exist between the audiogram and their listening strategy, but also in different classes of payer and the FDA and what we're willing to do. All right, so we want y'all to recognize who are falling in the gaps, and we want you to have a really low threshold to send people over for our assessment. So this is a picture of our Implant Team Plus, and we did a nice little dinner together here a couple weeks ago. But I put all the names of our implant surgeons and our audiologists on this slide, and so you can reach out to any one of them. If you have a hearing test, you know, you can shoot it over to us or whatever, and we're going to tell you whether or not we should send them or not. And our audiologists, even our clinical audiologists who aren't members of the implant team, are actually well versed now in who to send and who not. So if you're seeing an individual, say like in like comprehensive clinic or whatever, and the audiologist is like, yeah, maybe send you for a CI evaluation, then do it. Then do it, because again, they've gone to a lot more talks and lectures on it. Then we've been able to get to the physician side. And so, you know, just again, a really low threshold to send them. The worst case scenario, they're doing fine, and we know they're wearing the appropriate technology, all right? But there's a lot of opportunity even in between to get them better amplification or help carry them along, okay? So that is all I have for my grand rounds presentation. We have a few minutes left for questions, and then we'll transition into the didactic lecture when we think we've exhausted this. All right, so I really thank you for your attention. I hope this has helped you see these individuals in a different and hopefully more nuanced way.
Hey, Erika, I have a question to Sam. Thank you for that talk. That was super interesting. And honestly, the tinnitus thing blows my mind how important it is on the adult side, because we don't even think about it on the ped side. But my question is, what do you use as your gauge of improvement in adults? Like in the UHL kids that we look back on, you know, they would get above 50% on their AZ bios, but then, you know, wouldn't do as well on CNC words because it's harder. But to me, the AZ bios still suggest some benefits. So I'm curious, do you guys strictly use CNC words in adults to say successful or not? And what is your cutoff for what you call a success?
No, I mean, we meet the patient where they are. Some patients, they're really good, and we have to use a harder test to get them above the ceiling, right? So if they're getting over 80% on the AZ bio, then they're at the ceiling of that test, and then we start giving them harder stuff. We give them AZ bio with background noise next. If they do really well on that, then we'll do CNC words, all right? So we try to figure out what test is most meaningful for that individual. But even the patients who aren't star performers, even those individuals that I look at their scores and I'm like, that's not really that good, or that's not a lot better than they were before surgery or whatever, those individuals will still subjectively report, how much this changed their life, right? Or you'll notice just when you're seeing them in the office with your mask on, that all of a sudden you can do that and you're not having to type out all the words. So what's nice about adults is they can be very candid with you about the real world improvement they have, which sometimes the scores don't predict. It's rare for someone to get no benefit. Again, sometimes this is a matter about finding the most meaningful test for them.
What do you use to measure the subjective improvement? SSQ, or do you guys have another measure for the adult side?
Well, we use the SSQ, we use the hearing handicap. So those are the major things that we use. And they do show the benefit.
Gotcha, thank you.
Mm-hmm. Other questions? Any questions from the room?
Have you implanted anyone just for tinnitus alone? I know insurance probably wouldn't cover, but if you had somebody like show interest in this tinnitus is driving me crazy.
So still ask if we've done something for tinnitus alone.
Like if they don't meet, criteria from a hearing standpoint, but they still have some hearing loss, does the tinnitus aspect push you to implant them more?
The tinnitus aspect does cause us to push a little harder. We've not been able to get anybody successfully implanted who's been above criteria. I mean, if they're really above criteria, like, we're not gonna really recommend it. But if they're not meeting the basic criteria, like they're saying, if they're doing 80% of hearing aids, like we're not gonna touch that with the CI. But it is, if we can slide in there that they don't just have hearing loss, they also have pretty stable tinnitus. If we can slide that tinnitus code in and emphasize that on our clinical assessments, then it's been a lot easier to get those implants approved for single-sided or asymmetric hearing loss. So knowing this is there and emphasizing that in the eval has been important.
You gave some examples of how we are pushing the boundaries for what we're doing here. Are there other centers that are doing things that we wouldn't do here? Like what is the next more inclusive criteria?
Mm-hmm. So I think, I alluded to this earlier. Kevin asked is there anybody doing things that are more boundary pushing? Again, I think doing second side Medicare ones is kind of boundary pushing, not like scientifically, but medically legally. But we really pretty much are right. Like we pretty much are right on the edge here, and we have been one of 3 clinical sites looking at expanding the full-length permit either way, the 632 to hybrid level criteria, and we've been one of the 3 sites nationally for the FDA feasibility study. And we're the only site so far that's actually implanted a patient. And so, yeah, we're aggressively pursuing candidates, and that's something that our program is known for nationally. So we've been able to grow every year. Since Dr. Sadowski and I have been together 12 years, even our COVID year, even 2020, we did more implants than we did the year before. Mm-hmm. Yes.
I just have a quick question. So I did some rhinology clinic, and we had a lot of patients on medicine. Mm-hmm. And I know that immunoglycoside is what's happening at the stage of toxicity. So I was wondering if that's something you can do.
I mean, I've not seen it from nasal rinses, but certainly we've had some patients who have, CF, who've had just a ton of parenteral therapy or long-term nebulizer therapy that have resulted in hearing loss. A few years ago, I implanted a young woman who was on the lung transplant list. And she was doing really well with her implant, ultimately had a transplant complication and we lost her, but was doing really, really well with the CI. You know, we were able to keep her functional for quite a bit of the hearing. So yeah, so ototoxicity is a perfect reason to introduce cochlear implant as a concept, if that's platinums or glycosides or whatever else. And radiation, we use it for still. Dr. Hafford, you have a question?
Yeah, for the single-sided deafness in children, the age of 5 being cut off, is there like anything that we're doing as like a push to lower that, or are we doing it lower more aggressively if it's like a clear indication?
Yeah, I mean, if we find it, yeah, we'll try to nudge it forward. We'll try to nudge it. And maybe Sam could speak about that a little bit as well, if she's still on the call. So yeah, I mean, we'll want to implant them earlier. The question is whether or not we can just get the insurance company to approve it or not.
Is private versus Medicaid better with it, or they're both equally?
No, I mean, we just gotta push for it on a case by case basis. You know, but there are some people who are like, oh, we gotta wait till, you know, they're 5 years old. And it's like, well, why? We wouldn't do that in any other reason. So we'll try.
Yeah.
So brains, but we don't see it as a barrier. Sam, you want to weigh in too?
Yeah, sorry, you were cutting in and out from me, but it's better. And the sad part of it is, you know, less than 7, I would say, is more of a home run in terms of getting benefit for these kids. And then 5, you know, is approval age, so they're already getting to us later than they should. But then the younger they are, the harder it is to test them for candidacy and to be sure that CI is the right answer. I don't know if any Carmen's on the phone or any of the CI audiologists can comment on that, but yes, we're definitely trying to push earlier and earlier, and we are going ahead, and sometimes insurance will approve it because they don't look at the age and accidentally approve it, but definitely.
We put that in small font. Smaller font. All right, other questions? Anybody on the call? All right. Well, Jamie, I think that probably wraps us up for grand rounds.
Yeah, thank you so much. That was so practical and very comprehensive, and a lot of things that we didn't realize in terms of expanding the indications. So thank you so much. Hopefully this will also help increase the number of referrals for patients getting CI.